I'm going to invite Professor Stephen Mansberger, who is the professor and chair in University of Portland, Oregon. He is going to talk about how to use OCT in the glaucoma in clinical management.
Good evening. It's great to be here. Thank you to the organizers for inviting me. So I thought I'd try to give you some practical ways of using OCT in your clinic for helping to manage your glaucoma patients. These are my disclosures. We do receive some equipment from Heidelberg for some of our research. So first of all, I just want to go over the importance of structure with glaucoma. And when OCT is not accurate, this is going to dovetail, I think, to Dr. Azrani's talk a little bit later. When not to use OCT, when you're just wasting time, and which modality do I typically use? So this is just some longitudinal clinical studies that look at the rate of progression of our glaucoma patients. You can see here that a large proportion of our patients are getting worse over time. And it just kind of shows to us that, if you're not detecting glaucoma progression, let's say between 10 and 35 or 60% of your patients, you're probably missing a fair number of patients that are progressing in your clinic. And the probability of blindness over a long period of time is pretty high. In the Olmsted study, which is based in Mayo in Minnesota, the probability of blindness in 20 years was 27% in one eye and 9% in both eyes. And of those just initially treated for just ocular hypertension, it was 14% in one eye and 4% in both eyes. So even patients that don't have any optic nerve damage, but just elevated pressure, can go blind. This slide comes from the ocular hypertension treatment study, which showed that of those that develop glaucoma, more than 50% of them, 57% of them, develop glaucoma just based on structure. So again, the importance of OCT and looking carefully at the optic nerve. So there's lots of different algorithms for using OCT, and I'll just kind of tell you, what I use and why I use them. There's the sectoral scan, which is this imaging on the left, which takes a slice on multiple different quadrants in a clock hour type pattern around the optic nerve. There's a circle scan here that takes a circle image right around the optic nerve to get nerve fiber layer thickness, and then there's the macular scan. So how do these differentiated? The circle scan is probably the most common one that we see in the United States. The highest sensitivity to progression, so changes in OCT retinal nerve fiber layer thickness, it's the highest sensitivity. It's common to all the devices, and the nice thing about it is easy to plot longitudinal or values longitudinally, and there are a little bit differences in measurement technique, but it works pretty well in all the machines. And so this is kind of an example, and the way I explain this to my patients is what this is going to take a thickness measurement around your optic nerve. We're going to unroll that measurement here, and then we're going to compare you to a normative database, and then here is where your data, whether you're normal here, and then outside normal limits here. But this one it can be, and this is something I've been interested in, into segmentation errors, where the machine will mix up where the nerve fiber layer is. And so this is a paper that we published which looked at the auto segmentation here. You can see this red line, but it had missed this area here. It thought the thickness was too thin here, and so with manual refinement, the thickness actually is increased. And what we found that this auto segmentation errors occurred in a large proportion of patients with glaucoma. The interesting thing about this was, and Sanjay will probably go over this a little bit more, Dr. Azrani, is that these segmentation errors occur with worse glaucoma. It occurs in areas where the blood vessels are, which are the areas that we detect changes in glaucoma. So it's really an annoying thing, but maybe artificial intelligence will improve this in the future, and we're working on that currently. You see artifacts from vitreous traction. You can see this patient who you might think, if you just looked here at their plot, you think, oh my God, this eye is normal, but you can see this vitreous attaching to their nerve fiber layer and actually making their thickness much thicker than it would be. And then when this releases, it'll seem like their nerve fiber layer thickness became thinner, which is actually just an artifact of the vitreous traction. And then this is something else that we've been very interested in. We've been finding these areas of schisis. And so this is a really patient that I followed her for a long time, probably like 8 years before we got OCT. And then I was really mad because we got the OCT and you could see this schisis was occurring. And it's actually right here. You can't see it when you look at her just with ophthalmoscopy. And it doesn't, you can see a little bit of a hint of it here on the OCT in-FOS image here. But then you can see the schisis here. And it led to a project that we wanted to look at how often the schisis occurred. And, oh wait, I'm going backwards here. And so this is just an example of a patient with schisis in this area here. This is the same one here. It's here too, and then it goes away. So it kind of softens here and then goes away. This is a different patient with a schisis right here. It goes away about 5 months later. So this is another one of gives false positive and false negative results to the OCT. So the point about this is just look at your scans to see if you're seeing these unusual things there. Oh, this is just one other example of where the schisis was occurring in so many different layers. We published this, I think, at IOVS. But you can see a schisis occurring here in the nerve fiber layer here, and then going away, being totally normal here, and then getting a schisis in 2 different locations, and then going away for the most part. And then I think we had something coming back here. But anyway, we think this schisis is a really interesting thing, and it's part of the pathophysiology of glaucoma. It's just not an artifact. It's part of what's happening with the pulling and tugging with glaucoma. This is some work from Brad Fortune from our group who believes this is Mueller cell dysfunction. The Mueller cells keep the cells together, keeps the retina together, and they become sick or tired, and you get this schisis occur, and then all of a sudden they recover, as you can see in those photos, and they start to keep the retina back together. So the OCT just doesn't show the nerve fiber layer thinning. There's this dynamic process happening. The other type of scan is a macular scan, and this is the easiest location to segment. It's comparable accuracy to the circle scan as far as progression, but it's inaccurate with coexistent macular disease. So a patient with drusen or epiretinal membranes or anything like that, this testing will not work well. But we think it's best for patients with myopia and with those that have parapapillary atrophy around the optic nerve. We also think this scan may be better for patients with, well, I already said this for myopia. And the problem with myopia is they get retinal thinning, they get parapapillary atrophy, which give these artifacts. They have the optic nerve tilting, which can give artificially thin nerve fiber layer thickness, and they can also have visual field defects that are completely stable. So this is a paper by one of our fellows, Jinwok Jun, who showed that one area of this with a macular scan, it was the most accurate of determining myopia from myopic glaucoma. This database, and Dr. Azrani did an editorial on this paper too, but this database did exclude patients with drusen. It also used a supernormal myopes, meaning that their optic nerves were used as a criteria for inclusion. So, who knows whether this is really the best way to determine myopia versus glaucoma, and we're also doing some work in this space. And then finally, the sectoral scan. This is something that was popularized by Claude Burgoyne and Bao Chowan. What this does is takes multiple different sectors of the optic nerve, and then you segment the Brooks membrane opening. This Brooks membrane opening creates a minimum rim width, and we think that this is less, we think it's less sensitive to early progression, but we think there's less of a floor effect. So if you have somebody who's gotten a floor effect with the nerve fiber layer, which I'll show in just a second, this might be the best OCT to go to. So all of our instruments for OCT have a floor effect, and what that means is you're going to do this testing, and you're not going to see anything changing on the OCT because the patient is as thin as they're ever going to get based on this, on the OCT. And so it's something about 49 microns with a Heidelberg, up to 64 microns with the OptiView. And this is when you don't need to do an OCT. If they're at the floor, then you don't need to do it. So what do? I typically use the circle scan. It's just simple for my clinic when I'm seeing 50 and 60 patients a day to have the technicians doing the same type of test for every patient. And what I do is I kind of explain this, what I do with the patient, but this is a patient, for example, who's got one eye that looks like it's normal, one eye that's outside normal limits. And then I used an event-based way of determining whether they're progressing, and I use a 10-micron change from baseline versus currently. So what I do when I review my OCTs is I write down whether it's abnormal or normal, what the thickness measurement is, and then what the baseline measurement is. There's also a slope-based measurement, so if they're over 2 microns a year of thinning, that's a sign that they're progressing at a fast rate. And I also adjust these cutoffs. If they're looking thinner by about 5 microns, but it's somebody that's young with a high pressure, then I'm going to be more aggressive about treating them. And then I like to use this longitudinal plot. What you can see here is the original baseline exam, the subsequent exams, and then if you zoom in, you can see that this eye is progressing quite rapidly in several different areas. And if you've done an intervention in between then you might have to have a new baseline. And kind of the same plot here for the left eye. The left eye was progressing too. So my take-home points is without OCT, you are missing at least 50% of your patients with progression. Look for artifacts that create false positive, false negatives, and are part of the definition of glaucoma, we think. Use a standard method of following your glaucoma patients using longitudinal plots. And I think for, future testing will include a full cube scan. They'll just do a whole scan of the back of the eye. And they'll use AI to pick which part of the eye that it's best for this patient. And we won't have to pick between these 3 different scans for OCT. Thank you.